Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. As a reminder, this content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. By this point in the series, one thing should be clear. Insomnia is not one disorder, and there is no universal sleep medication. When clinicians say nothing works, what they usually mean is that the treatment did not match the mechanism. This episode is about fixing that mismatch. Think of insomnia not as a symptom, but as a systems failure. The question is not what helps people sleep. The question should be, why is this patient awake? The decision tree always starts with timing. If the patient is tired but not sleepy, wide awake late into the night, and unable to fall asleep until very late, especially with normal sleep once they finally do, this is likely circadian misalignment. Or delayed sleep-wake phase, shift work effects, ADHD-related circadian drift, or mood disorders with late-night activation. In these cases, sedatives underperform. The first line pharmacologic consideration is a circadian signal, not sedation. Melatonin agonists, particularly ramelteon or tamiceltione, fit here. Low-dose, precisely timed melatonin may also help, but only when paired with consistent wake times and light management. If timing is not addressed, no hypnotic will stick. If the timing is right, but the brain won't disengage, the decision tree moves to hyperarousal. This is the most common phenotype in psychiatry. The patient lies down exhausted, but the mind stays active. Rumination, anticipatory anxiety, conditioned wakefulness. The bed itself has become a trigger. In this situation, Z drugs and benzos may work briefly, but they will fail long-term. Here, the most rational pharmacologic choice is a wake drive reducer rather than a sedative. Orexin antagonists target exactly this mechanism. They lower nighttime alertness without suppressing cognition or REM sleep. They don't force sleep, they stop the brain from fighting it. This is also the type where CBT-I is non-negotiable. If the patient falls asleep easily but wakes up repeatedly or wakes up too early and cannot return to sleep, the problem is often sleep maintenance. Here, the question becomes, what's pulling them out of sleep? If awakenings are quiet but frequent, low-dose doxepin is worth considering. At 3 to 6 milligrams, it targets histaminergic arousal without broad neurotransmitter disruption. Orexin antagonists also perform well here, especially when hyperarousal is present. If awakenings are driven by anxiety surges, trauma-related hypervigilance, or panic, pause before escalating sedatives. Benzodiazepines may reduce arousal short-term, but they reinforce dependency and worsen long-term sleep stability. These cases demand a combined approach: careful pharmacology plus CBT-I and trauma-informed care. If insomnia is situational, like acute stress, grief, medical illness, or travel, short-term pharmacologic support may be reasonable. This is where Z drugs or even short, tightly time-limited benzo can be used appropriately. The key word is time-limited. No refills without reassessment. No silent conversion to chronic use. If insomnia is chronic, meaning 3 months or longer, the decision tree changes completely. Pharmacology becomes adjunctive, not primary. One more critical branch: comorbidity. If insomnia exists alongside untreated sleep apnea, restless legs, circadian disorder, substance use, or poorly controlled mood or anxiety disorders, No hypnotic will perform reliably. Finally, there's a category clinicians rarely name out loud: learned insomnia. These patients have tried everything: multiple medications, supplements, apps, podcasts. Nothing works anymore. In these cases, medication resistance is not pharmacologic, it is behavioral. The brain has learned to stay awake in bed. More medication only reinforces the pattern. The decision tree ends where many clinicians feel least comfortable, but where outcomes improve the most. That is CBT-I. Not as a last resort, as the core treatment. The real shift in modern medicine is not about choosing better drugs. It is about choosing when not to use them. The right medication for the right mechanism in the right window, paired with behavioral retraining, is how chronic insomnia actually resolves. And that's where this series yields. Because insomnia is not cured by stronger prescriptions. It is resolved by better alignment. If you have just joined us this episode, check out the full series on sleep and mental health, where we discuss different classes of sleep medications. See you in the next series on antipsychotics. Bye!